Welcome to the LDN radio show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. Today, I'd like to welcome back one of our medical advisors, Dr. Yusuf Saleeby, who's known as JP. So thank you for joining us, JP.
It's always a pleasure to join you on this program.
So for our listeners, let's learn about you, people that don't already know you. What is it that you actually do?
Sure. So I would consider myself a practitioner of functional and integrative medicine. My background is emergency medicine and internal medicine, but I stepped away from that in 2013 to focus entirely on functional medicine, which is really a deep dive into root cause. And we take care of a lot of chronic illnesses that other people have sort of given up on. So that's what I do. I'm heavily involved with the FLCCC. They just appointed me as a senior fellow for the Americans, which is I'm one of about 12 in that category. And I'm working with a couple other national organizations on trying to rehabilitate or create a new educational system for doctors and nurse practitioners and PAs. So we're very focused on that so we can do a better job of training folks coming out of their residency or medical schools in the arena of personalized care.
Well, that's so important because in the 20 years of the history of the LDN Research Trust, so many of the doctors we relied on have retired. Mm-hmm. So we've got to keep getting new blood. People coming through. So we know that you can prescribe LDN nationwide. Could you tell us, do you have to do face-to-face? Can you do telemed? How does that work?
Right. Well, I am part of a national group. It's comes from a tradition of Native American healers. So I am classified as a certified tribal practitioner. That gives me, through the First Nation Medical Board, the opportunity to see patients all over the United States. And we also have an international following of a few patients here and there internationally. The way this works is it's actually enveloped in what we call a PMA, Private Medical Association. In other words, the patient has to commit to that as well as the practitioner. Once that's established, so we have that with the First Nation, and I also have one with my own practice. I just transitioned from an LLC to a 508c1a nonprofit. So we're now a nonprofit organization that has a private medical association agreement. So once both parties are involved with that, then there's the free reign of taking care of people via telemedicine. Does not have to be in person. And we're about, myself, I'm about 70% telemedicine on all my patients. My other two practitioners, and we're having a third one join us in July, they are about 50% telemed. So we're heavy on the telemedicine, and most of what we can do very nicely is via telemedicine only. On occasion, we need to bring the patients into the office for an examination. And some people fly in from out of state for one visit a year. So it works out pretty well. We know our limitations. If you have to examine something up close, or, a skin rash, or look in someone's ear or down their throat, it's not very possible with telemedicine. So we do know our limitations. And if that sort of an examination is required, we usually bring the patient into the office.
Mm-hmm. How long typically is a consultation?
Yeah, so they're very individualized. So if it's a simple case of, let's say, a mother who wants her child to be placed on LDN for a trial for behavioral issues or for an autoimmune disease. And it's very simple and straightforward. Sometimes it's a 30 to 45-minute consultation, and we have pricing structure for just that. If it doesn't go beyond just like, let's test the LDN on somebody. If they want more personalized, and let's say they have a history of Lyme disease and mycotoxin illness, and they've got heavy metal toxicity, or maybe are very sensitive to electromagnetic fields, that's a more complex patient. That may wind up being an hour-and-a-half consultation. So it's very individualized. It depends what the patient needs and what we need to kind of get down to the root cause of their problems in a consultation. So it's not a one-size-fit-all. It's very individualized.
Mhm. So the medications that you prescribe, and LDN being one of them, how do you go about prescribing the LDN? Do you start low and go slow? How do you find the optimal dose for a patient?
Right. With regards to low-dose naltrexone, and I'm one of the biggest prescribers in the state of South Carolina, I like to go slow and low initially. I know there's about 100 different ways you can prescribe it. Some people start with 1 milligram, some with 1.5s, and they, will double the dose every 2 to 4 weeks. I mean, everyone's different. Every practitioner, that is, even within my own practice. I tend to find my patients, my demographic of super sensitive, highly complex patients, that they do better if I start low. So sometimes I'll start with 0.5 milligrams or even 0.25, and then titrate up to anywhere from the range of 3 to even up to 6 milligrams. I sometimes split dose. In other words, their total daily dose may be 4 milligrams, but they take 2 in the morning and 2 in the evening, 12 hours apart, mostly with pain, and usually in combination with cannabinoids like CBD or things that have Delta 8 or Delta 9 in them, and some other agents as well. And that seems to work very nicely for pain modulation. So it's different for everybody, and the pace in which they escalate their dose is also different. If I've got the luxury of waiting and doing it an increase every month, i.e. every 4 weeks, I'll prefer to do that. But there are some patients with aggressive cancers that we can't wait that long, and I'll escalate their dose every 2 weeks or even every week to get an effective dose.
Mhm. So side effects, what have you noticed?
Not much, Linda. This is a very well-tolerated drug, and I do believe if you start low and escalate the dose slowly, you'll have fewer complaints from your patients. The ones I most see complaints from are those with tick-borne illness, Borrelia burgdorferi, which is Lyme disease, and Bartonella, some with Babesia as well. And those folks tend to herx if you start out too high and go too fast. And the herx or Herxheimer reaction is a die-off reaction. You can see that with those with tick-borne illness, and also those that have been spiked. What I mean by that are those who have been affected in a bad way by the SARS-CoV-2 virus, whether infected or injected. So we have a multiple infected patient with multiple variants. They come in, they tend to be very sensitive, and they may have a little bit of an untoward effect if you start LDN too high. Symptoms being things like dizziness, fatigue, headache, hair loss, ringing in the ears, those kind of things. I don't see too much in the way of really harsh side effects, so I tend to, back down. I don't quit. Sometimes we'll give them a holiday. I'll say, okay, take a week off, and let's start at a lower dose. My biggest fear is that if you start too aggressively and they have a side effect, they're going to be discouraged and disinclined to want to restart that medication. And it's just a shame because in my experience, LDN has been a kind of a magic bullet for many autoimmune cancer, Lyme disease, people who are immune deficient, people who need to have their mTOR turned off, people who have to embellish or modulate their immune system. So it's a great tool in my toolbox. And I hate it when somebody says they don't want to take it anymore because at one point in the past, somebody put them on too aggressive a dose.
Mhm. I know how long is a piece of string, but how long would you say if somebody says it's not working for me, there's no point in me continuing? At what point would you say, okay, it's not working?
Right. So it depends what dose they've landed on. Now, if they come to me after 3 months and they've only been up to, 0.75 milligrams, I'll say, well, the dose isn't aggressive enough. What's the problem? I had a patient last week who got the prescription 3 months ago and hadn't started it yet. So I told them, I said, well, you're not going to know if it's going to work if you don't take it. So it depends where they've landed. Now, if they're all the way up to 6 milligrams a day and they've been doing it for 6 months and they don't feel anything's happening, I'll ask them to take about a 2 to 4 week pause. And oftentimes, this happens about half the time, people will come back and say, you know what, I didn't think it was doing anything, but obviously it was, because when I stopped taking it, a lot of my symptoms came back. I'll also get this same story from people who are like on the fence about it. And let's say they run out of their prescription and they're thinking, well, I'm just not going to refill it until I see Dr. Saleeby again and we'll see what happens. And on that visit, they'll say, you know what, I ran out and within 3 days, I knew I really needed it. So that is kind of like one of the biggest, best ways for them to be compliant is when they know it works. And sometimes by an inadvertent non-refilling it and running out, it's a lesson they learn.
Mhm. Working with patients and giving it time, what would you say your success rate with LDN is?
I say a success rate without having any side effects. So that's one part of the success, is if you prescribe a medication and it doesn't cause any untoward effects or side effects. I'd say that's around 80 to 90% of my patients don't exhibit any side effects that would make them want to quit it. You can't say that for many of the pharmaceuticals out there. I had a cancer patient who was taking a very aggressive drug and it was making her suicidal. So it changed her mood and it put her in a very dark place. So we've been trying to get her off of that with the use of LDN. But as far as success in managing things like autoimmune disease, MS, and Lyme disease, and folks with EMF sensitivity, folks with a host of autoimmune diseases, I think my success rate is up somewhere between 75, 80%. And that's observational. I don't do randomized clinical trials in my practice, but this is from years of observation. And we have a pretty good success rate.
Okay. So when a patient comes to you with a complex condition and it's telemed, where do you start to try and find the roadmap to get them to where they need to be?
Well, oftentimes those sort of patients come to us after being to at least 12 to 15 different allopathic doctors, non-functional, non-integrative, sometimes from big hospital systems and very big systems with big reputations. And it turns out that they don't really get the attention they need. They get short visits. They get a lot of lab work. They get a lot of studies, CTs, MRIs, PET scans, you name it. They get all these fancy studies. So part of it is going through their health record, reviewing all the labs that have been done, and then taking what we call a functional medicine history. Now, when they're in the office, we also do a pretty good physical exam. But, I think it's been my experience, and the more I do this, the better I get at it. I can usually, after an hour to an hour and 15 minutes on a consultation, whether on the telemed, the phone or Zoom, or in person, just by doing a history and the kind of history we ask some very peculiar questions, but we're trying to dive deep into where their health started to go downhill. And after that, I can make a diagnosis 85 to 90% accurate after just that one encounter. Now, if there's some issues, if I have a differential diagnosis and I need to determine if it's this or that, is this true MS or is this Lyme disease? Is this a Parkinson's-like syndrome? Is it true Parkinson's or is it a stealth infection that's mimicking Parkinson's? Then some testing would be in order. But I find that as I get older and more experienced, I rely on testing less and less. Now, some of my new providers, my new graduate from IFM, she's heavy on the testing because she doesn't have that clinical experience yet. So you want a clinician with a little bit of gray hair, not too gray, but just enough that they're experienced, and they won't over-test. So I hope that answers your question.
Yep. We've got a documentary coming up on MCAS, and I've been interviewing many patients with MCAS who are looking for a provider that isn't going to dismiss them as that their symptoms are psychological. And the list of symptoms some of these people have and have had for 2 or 3 decades, it's unbelievable that it can still be called psychological.
Yeah.
What would you do in that situation with someone with MCAS?
Right. So MCAS I'm very familiar with. Even pre-pandemic, we were seeing a lot of MCAS with Lyme disease and mycotoxin illness. It is probably one of the underprescribed conditions because there's a lot of nuances to it. Everything from skin changes on the shins to not just laboratory analysis of some biomarkers of histamine release and LPS antibodies and lower levels of the enzymes that degrade histamine. And there are inflammatory markers you can look at. But again, a good history and physical exam can lead you to that diagnosis, and it's underdiagnosed. There are way more people out there with MCAS than the medical community will attribute. And as far as functional disorder, like psychiatric disorders, that's a diagnosis of elimination. You've eliminated everything else organic. And it's, when you don't have an answer, you've dug and dug and dug and nothing's coming up. And then you have to kind of say, well, maybe this is a psychiatric illness. But you don't call somebody out like that at the first visit. I mean, this takes time and a proper medical workup before you say, well, we can't find anything organic. It's got to be functional. It's got to be psychiatric. So, there's a lot to it. I give lectures on it. I have a couple of lectures on MCAS. We've had a couple of master classes where I've given the lecture, and we've had other people lecture on that topic in our academy. And the academy is where we teach other clinicians the ways of functional and integrative medicine. So I'm very astute at MCAS, and I've seen a big climb in the number of patients since the pandemic 4 years ago. We're in the pandemic now 4 years, and we've seen a big rise in those presenting with MCAS, along with the fact that we're more attuned to it now. Our little antennas go up when we start hearing certain symptoms or see certain signs. So, and there's a lot to treating it. LDN is one of the tools we use. There's our agents like amloxanox, rapamycin, of course, montelukast, your leukotriene inhibitors, your H1, H2 blockers. There's a whole cascade of things we will try on people, and then even energy medicine, acupuncture, and some other things that will help with managing MCAS.
But with it being a multi-organ condition, some of the doctors that are presented with a patient like that just say, I haven't got time. You've got too many things wrong with you. And not being listened to and not being believed is really upsetting for these patients when they are feeling so ill that they can't get out of bed, they can't function, they can't go out or do anything, yet they're made to feel it's their fault. You know,
Right.
it's terrible. So,
Right.
you know, thank you for what you do to help these people.
Sure. Yeah, it's, you know, if you're seeing a clinician that gives you 3 minutes, you can't make a diagnosis. And they'll say, oh, you know, here's Benadryl for the itchiness, and here's some Zoloft for your mental health. And that's just no way to treat a patient. And they're gonna suffer. They'll go another year or two without proper treatment. So the patient has to realize there's better out there.
Mhm.
And it doesn't come within the insurance model, unfortunately. People pay a lot of premiums for their health insurance. I know in our country, Linda, in your country it might be a little different, but in the US, people pay large premiums for healthcare that they'd like to use. But unfortunately, that system is not the best system to be in when you're dealing with a lot of chronic illness, including mast cell activation. So the patient has to kind of jump over the fence to the other side, if you will.
Mhm. Well, currently our waiting lists are very, very high. Our hospitals can't cope. It's all in the news that, you know, the NHS is broken. And I have to say that so many people, even though we've already paid into the national health, go private because they need answers and they can't wait years to find out what's wrong with them.
Right.
It's not easy wherever you live, I don't think. And our system, if you want to get help from your doctor, you have to live in the area that that doctor covers. So if you know there's a really good doctor in an area just outside of where you live, you can't see that doctor because you have to become a patient of that doctor.
I
So
see.
that
Wow.
that that's tricky. That's
Yeah,
tricky.
it is. I know healthcare worldwide has really suffered in the last couple of decades. And there are organizations, and Linda, I have to, you know, say that you've done a lot for medical education, trying to win doctors over to understand there are better ways to treat your patients. So kudos to you for your dedication to furthering things, especially things in the realm of low-dose naltrexone. But there are many other organizations trying to revamp or change healthcare. I know in many different countries. I know there's an issue in Australia and Canada. It's not just the United States, but our system is really quite broken.
Mm. And it's unfortunate for those people that have got cancer who have not been able to get to see a medical professional in time, you know,
Hmm.
and it's fully blown and oh, terrible. But if anybody's listening and they think they would like to try LDN, but think, but I'm on heavy duty painkillers, so I can't take LDN. What's your answer to that?
So we have several that have come into practice on pretty heavy doses of opiate and centrally acting painkillers. So we go on a program, if we can, properly and very carefully wean them down. We start some other things first, and then to support them, and then we do a taper of their opiate medications or anything that's contraindicated. The other option is to use ultra low dose naltrexone. So we use micro dosing uh, of naltrexone while they're on their opiates as we're tapering them off. It's a little trickier. Not everyone responds the same way, so we're very cautious. We don't want to ever incur a total blockade where they go through withdrawals. So we're very careful in how we do that. And again, titrating down with their opiates as we titrate up with the LDN. So there's a little trick to doing that. But if we have the opportunity, we get them off their opiates first, and then we immediately start low dose naltrexone.
Mhm. Okay. So, have you any advice to patients who are absolutely bedbound, can't get out, feeling absolutely awful, where do they start?
I think the starting place for those patients, especially if they've been around and around with allopathic medicine, like traditional Western medicine, with no real good results, is to seek out somebody who's trained in functional integrative medicine, somebody who will spend an hour, hour and a half, even 2 hours with them to try to get to the root cause of why they're in that condition. And I think they'll have better success pursuing that. And they have to realize that those practitioners are usually not part of the national healthcare system or in the insurance model, that they are usually independent, what we call DPC, direct primary care practices, or cash for care, if you will, that don't have much to do with the insurance model because it's not compatible. I mean, doctors won't get reimbursed for spending that much time with their patient. They're expected to see 30 patients in one day. There are not enough hours in the day to do that in the functional medicine world. You know, I cap out usually about 5 or 6 patients a day. That's all I can handle. And you know, that's why I have 3 other practitioners in my practice to help with the workload. But I'm not going to sacrifice that by saying, oh, let me squeeze in 10 more patients today and be unable to do a full time and attention that these patients deserve.
And how can patients contact you?
So we have a toll-free number in the US, 800-965-8482, or they can go to our website, carolinaholisticmedicine.com.
And do you have a waiting list?
Yeah, we're short a couple of practitioners. We had 2 that left this past year to pursue other things. So we're down to 3, but we have 2 perspective. We have one that we're hiring full-time that's coming on board just after July 1st. So that's not too far away. And then we're looking at hiring another part-time. So yeah, I have a waiting list, as well as Chris Jackman, my associate partner. But Wanda, our newest addition, doesn't have much of a waiting list. And then once Parag joins us, that waiting list will probably dissolve. Will go away, and we'll get people. We usually are able to get people in within 2 weeks.
That's wonderful. Well, thank you very much for talking to us today.
Very good, Linda. Like I said, it's always a pleasure joining you on your show.